Hari. So පටන් ගමු නේද? Okay.
හරි සර්.
So this is the first one then. Now this particular session that we are doing today has almost everything that can be asked in your exam. And it gives you the sort of broad themes of what they will ask you. Making නැති දේවලුත් තියෙනවා. Now, for example, regarding your sort of resuscitation, acute medicine training program that we have conducted. So please just revise that. CPR දෙන එකක් වගේ දේවල් ඒවා විතර දෙනවා. Then of course the usual sort of communication skills and other sort of breaking bad news, that sort of nonsense also you will get. Sorry. Right, now if you have gone through this case, the main idea is to identify the theme of this station. This first question is for you to know how to identify basic sort of dermatological spot diagnosis. Dermatological spot diagnosis. Meka mokadda? What is this? So we'll come back to the question, but essentially what is this? Picture left, and there's some pictures of nails also, very common thing when you what you get at the exam. Yeah, so this is very clearly psoriasis, and why this is psoriasis is because see this sort of silvery pinkish scales with sort of silvery pink silver. That's very nice to see. And it's very important that this plugging the hairline, right, which is quite typical of psoriasis, right? The plaque is crossing the hairline, typical of coming the hand of the connection ප්‍රශ්නයද දන්නේ පොඩ්ඩක් කරගෙන යා.
පොඩ්ඩක් බ්‍රේක් කරනවා සර් මැද්දෙන් වොයිස් එක.
ඔව්. connection ප්‍රශ්නයක් වගේ දිනනට වෙයි කියලා.
Hari පේනනේ screen එකයි.
ඔව් සර් පේනවා.
Hari. Right. So this is psoriasis, and on the fingernails you can see the sort of very nice nail pitting, and you can also see that the nail has been lifted off the nail bed, right? Especially you see this in the fifth fingers, right? You see, show that to you, but right? So you can see that a part of the nail is lifted off the nail, and that is onycholysis. So nail pitting and onycholysis are also a feature of psoriasis, right? That is, so this psoriasis. Okay. Now just put this case as a sort of question which you can attempt to But this patient with psoriasis, it says the patient was recently commenced on medication. And you can see that there is quite severe neutropenia, okay, where the absolute neutrophil count is less than 500. And the patient has fever and a high CRP. So the picture that we see is clearly that of neutropenia, neutropenic sepsis. What is the medication you might give a patient as cause in sepsis, Lamai?
Especially a patient with psoriasis who has joint involvement, you might give us a medication which can cause a low white count, low neutrophil count, and can have secondary infections. Why not to කියන්න දැන්? අද අන්තිම දවසනේ මේ කරන්නේ. I think
methotrexate.
can. Hi. Now, apart from this picture, there are other important dermatological spot diagnoses that you can get in the exam. Now, I can't give you all the ones that we can give the exam. I see a few comments for today's discussion. Sorry. This is the few causes of erythema multiforme. Few causes of erythema multiforme. Reactions are quite common, especially anti-epileptics. You get erythema multiforme, and the most severe erythema multiforme involving the mucosal surfaces is Stevens-Johnson syndrome. That's that. And make a cutting group a painful nodular rash on the shins.
ඇහෙනවා සර් මට ස්ලයිඩ්ස් වල තමා ඩිලේ කියන්නේ සර් එක්ස්ප්ලේන් කරන ස්ලයිඩ් එක එන්න වෙලා යනවා සර්
වෙලා යනවද දැන් මොකද්ද පේන්නේ කකුල් දෙකක්ද පේන්නේ
දැන් කකුල් දෙකක් පේන්නේ
ඔව්නේ
දැන් පේන්නේ කකුල් දෙක
ඔව් හරි ඕකේ රයිට් අද පොඩි ඩිලේ එකක් තියෙනවා මේකේ සමහර දවස්වලට ඉන්ටර්නෙට් වල පොඩි ප්‍රශ්නයක් තියෙනවා මම දන්නේ මොකද්ද කියලා right so this patient this is a if I give a history saying this is a painful nodular lesion in the shins so it's erythema nodosum and again like erythema multiforme you need to know a few causes erythema nodosum it can be secondary to certain underlying systemic illnesses. The important ones you need to know are it can occur primary tuberculosis, primary TB, sarcoidosis, okay, primary TB, sarcoidosis, and also inflammatory bowel disease. It is one of the extra-intestinal manifestations of inflammatory bowel disease. Extra-intestinal manifestations of inflammatory bowel disease. Hari, etika harida ahunada?
ඔව් සර් ඇහුණා. දැන් හරි.
Hari. Hari ne? Okay. This is again a very common spot diagnosis you can get. Right, malar rash. Okay, you can see this very nicely, malar rash, and a rash in the photosensitive areas. Right, what is this?
SLD.
Okay, SLD. Somebody has said erythema multiforme එවිතිය multiforme මං කිව්වේ mainly මේ drug eruptions කියලා. හරි? Main cause. Hari. So this is SLE. Okay, SLE. Now this is again something that you can get, right? This patient has systemic sclerosis. Okay, and that's quite clear. You can see the sort of very if you look from a side, you'll be able to see this sort of beak-shaped nose. Right? Beak-shaped nose, thick, shiny skin, quite typical of systemic sclerosis. They cannot open their mouth. Of course, you can't see that on this picture, but they cannot open their mouth fully and microsomia. And this white rash of the chest. So there's a whitish sort of rash in the neck and the upper part of the chest. That is called speckled leukoderma. Okay, speckled leukoderma. Speckled leukoderma. Right, so those are the features of systemic sclerosis. Thick, shiny skin, beak-shaped nose, microscope, and speckled leukoderma. Okay. And then you can also see in the fingers that the fingers are sort of flexed, right? Finger flexed. That's the skin in the hand also very tight, called flexion of the fingers. And in addition to that, you can see sort of tissue loss, tissue gangrene loss, and that can also occur in sclerosis in systemic. So you can get distal gangrene and tissue loss. Right? So that is another thing that you can see in this picture. Hari Deka.
Hari sir, hari.
Okay. Okay. Now, this is sort of Stevens-Johnson syndrome. Okay. And you can also see, you can see the extensive sort of mucosal involvement and also extensive sort of body involvement and mucosal involvement. So this is mainly Stevens-Johnson syndrome. You can also see a bit of skin peeling off. So they can see the skin is also peeling off. And sometimes you can have this Stevens syndrome overlapping with the other severe form of skin manifestations, which is toxic epidermal necrolysis. 10, toxic epidermal necrolysis. So this is actually a Stevens-Johnson plus toxic epidermal necrolysis. And the famous thing that causes this is anti-epileptic drugs. And this has been found to occur with lamotrigine, right, and carbamazepine, lamotrigine and carbamazepine. But there are many other drugs that can cause Stevens-Johnson syndrome or toxic epidermal necrolysis. But the classical ones that you should know, and they ask MCQs, is lamotrigine, Stevens-Johnson syndrome. Hari neda?
Hari sir.
Okay. Now these pictures are pictures of leprosy, right? And if you follow mouse pointer, the laser pointer, you can see this hypopigmented patch in the face, right? Hypopigmented patch in the face. If you see that, most likely leprosy. This is another classical picture in relation to leprosy, where you can see this. If you follow my pointer again, you can see the thickened greater auricular nerve. Okay, thickened auricular nerve. Yeah. So look for this cutaneous involvement, and these are the other signs as well for leprosy. Now, as an undergraduate, you do not really worry about subtyping the leprosy into tuberculosis, borderline, and leprosy, right? Again, ලොකුවට කලබල වෙන්න එපා, because it's mostly dermatology specialist stuff. But obviously, if this sort of thing you see, this is very clearly lepromatosis. Skin infiltration, these raised skin infiltrations in the forehead, right? And this is lepromatous leprosy. Okay, a leonine face කියන වචනෙත් අපි මේකට පාවිච්චි කරනවා. Leonine face. Right. Okay. ඊට එක හරියද cutaneous ඒවා ටික dermatology. So there you can get other things also, but I've just given you some of the common ones. Leprosy pictures දෙන්න පුළුවන්. Erythema multiforme, erythema nodosum, SLE, systemic sclerosis, psoriasis. These are the common things you can get. Right. හරිද ඒ ටික?
හරි සර්.
Okay. Right. So now let's move to the ECGs then. Now, when it comes to ECGs at the exam, you will have various types of ECGs. You will definitely get one with some sort of arrhythmia on it. Okay, some ECG with some sort of arrhythmia. Now, we discussed this before also when we were talking about cardiovascular emergencies. When you get a tachyarrhythmia ECG, you should be able to identify the diagnosis, right? Or the underlying rhythm diagnosis. Right? That is very important. Right? So this is a tachyarrhythmia ECG, and we need to identify the rhythm diagnosis. Now, as I taught you before, in tachyarrhythmia ECGs, your first classification, or your approach, the first thing you do is to see, is this a narrow complex tachyarrhythmia or a broad complex tachyarrhythmia? Right? Narrow complex ekadda, broad complex ekadda කියලා බලන්න ඕනේ ඉස්සෙල්ලාම නේ. That is very important. And as you can see in this picture, this is clearly complex tachyarrhythmia, right? Because it's the QR complex is 0.12 seconds, right? Or more or less. Right? So it's a low complex tachyarrhythmia, right? Now I have told you that narrow complex tachyarrhythmia due to the narrow complex tachyarrhythmia is from occurs. So it can be due to atrial fibrillation, atrial flutter, SVT or cardia or AVNRT. Right? Right? Right. So atrial fibrillation, atrial flutter, or nodal or AVNRT or SVT. It's called any of those three names. Right? Right. So this is a narrow complex arrhythmia. Right? So it can be atrial fibrillation, flutter, or AVNRT or nodal tachycardia. So now in nodal tachycardia or AVNRT or SVT, and because AV nodal area the abnormal rhythm arises from around the AV nodal area, you will not see a P wave before the QRS complex. Right? If you look at this, what is the diagnosis then here? So if it's a AVNR, now this patient has a AVNRT or nodal or junctional tachycardia. Why do we say that? Because it is a narrow complex tachycardia. It is regular, which is a characteristic feature of AVNRT always. And also you cannot see P waves. Why don't you see P waves? Because the abnormal current is starting from around the AV node, right? And actually the atria are being depolarized in reverse, right? Depolarized in reverse, right? And that causes something called retrograde P waves. If you look at my mouse point, you can see this retrograde P. Podi ekak metana tiyena right after the R wave here in B1, right? So that is something you can see sometimes, but don't worry about that. So narrow complex tachycardia can be due to atrial fibrillation, atrial flutter, or nodal tachycardia. Nodal tachycardia, the features like in this ECG are regular narrow complex and absent P waves before the QRS complex. You may see retrograde P waves. Hari deka, puluhan deka.
Hari sir.
Hari, okay, right. Retrograde P waves. Then, of course, we can ask you something about the management, which you have already discussed. Now, at the exam, you can also get other types of rhythm abnormalities. Other types of rhythm abnormalities and tachyarrhythmias, bradyarrhythmias. What is this? So this is not exactly fast, but heart rate එක 90 to 100 විතර තියෙනවා, right? It's a narrow complex tachyarrhythmia. What are the key features here? What are the key fibrillation or nodal or AV? The key feature here is this is completely irregular. The rate is completely irregular, right? In between the R waves. So the rate is completely irregular, and you can see this irregular baseline in between the R waves. Okay. So what is this? What is the diagnosis here?
Atrial fibrillations.
Yeah, atrial fibrillation. So why do we say narrow complexes? P wave not clearly present. There is an irregular baseline, and the R waves are irregularly irregular. That is why it is atrial fibrillation. V1, if you look at V1, you can see a sawtooth-like thing. Sawtooth gatiyak pena the V1. Now that is, you can see that this is not atrial flutter, right? You can see this sort of wave in V1. It doesn't mean the patient has atrial flutter and fibrillation. Maybe V1, you can see this abnormality even in atrial fibrillation. So don't make that mistake. It's a common mistake. Okay. Right. What do you think this one is? Now, this one again is a narrow complex tachyarrhythmia. But if you look at 2, 3 and AVF, you will see something very interesting, and that will help you to diagnose this. So what is this? Narrow complex but regular tachyarrhythmia, and you can see something going on in 2, 3 and AVF, especially with the P waves. What do you see? What do you see in the inferior leads, 2, 3 and AVF? The pain.
Negative P waves.
If you look carefully, I know the key level. Yeah, negative but if you look carefully, you can see a sawtooth P wave. 2, 3 AVF. It's like this, the edge of a saw. Right? So this is actually atrial flutter. And remember, these atrial flutter waves are best seen in these leads usually, inferior leads. So pain. So 2 1 pain. 2 where you can see the flutter waves. So this is atrial flutter, atrial flutter, atrial flutter, okay, flutter waves. So we have seen ECGs of atrial fibrillation, flutter, and AVNRT, which are the common things that you can get. All right. Now this one is a broad complex tachyarrhythmia. Ne? And I told you, if you remember, broad complex tachyarrhythmias can be due to ventricular tachyarrhythmias or tachyarrhythmia rising from above the ventricle with an associated bundle. Can have either ventricular tachyarrhythmia causing a broad complex tachycardia, or you can have a supraventricular thing but with an associated bundle branch block. Right. So these are the possibilities, right? Don't worry for your level. Assume that broad complex tachyarrhythmias are almost usually due to ventricular rhythms. It's very difficult to diagnose those types. So this is a regular broad complex tachyarrhythmia, which is ventricular tachycardia. This is ventricular tachycardia. And a characteristic feature of ventricular tachycardia is, if you take V1 to V6, you can see the QRS complexes are pointing in the same direction. QRS complexes are pointing in the same direction. This is called concordance, which is a feature of ventricular tachycardia. Concordance, concordance, right? So on the broad complex side, then lamai ventricular tamai godak velawata, but occasionally you can get something from rising from above the ventricles, a tachyarrhythmia rising from above the ventricles, but with a block on the way. Pallehata yana gaman block vela tiyena එක. හරි? එහෙම එකකුත් අපිට එන්න පුළුවන්. Right. So that's ventricular tachycardia. Now this I showed you when we were doing, or I told you about when we were doing ECGs and the cardiovascular emergency part. This is also a broad complex tachyarrhythmia, which is ventricular, that's true, but it has a sort of a nice shape to it. The height of the QRS complexes change. So this is Torsades-Dupont. This is Torsades-Dupont. Right? Torsades-Dupont, and the treatment for this is different from all the other ventricular tachyarrhythmias. Here you give magnesium sulfate, right? Magnesium sulfate. So this is Torsades-Dupont, and you can see this, the height of the QRS complex changing and causing a ribbon, twisted ribbon-like pattern, right? That's called Torsades-Dupont. Right? Okay. Now this patient, ඒ ටික හරියට tachyarrhythmia ටික ඇහුණාද?
ඇහුණා sir.
හරි. Okay. Right. Now let's move on to bradyarrhythmias. And bradyarrhythmias, the most important one you need to identify the most important one you need to identify are the AV blocks. AV blocks. The AV blocks revise karagattut, there are 3 types. AV blocks, 3 types. Right? So first degree AV block is where the PR interval is prolonged and there is nothing else going on. Right? It's just the PR interval that is prolonged. So long PR interval is the only thing that you see.
All QRS, all P waves are conducted down, right? So all P waves are conducted down. So every P wave has a QRS complex. Every P wave has a corresponding QRS complex. The first degree AV block, long PR interval, all the P waves have a corresponding QRS complex. Right. Now, second degree AV block is the basic principle of second degree AV block is some P waves are conducted and some P waves are not conducted. That is the principle. Right? So some P waves are conducted and some P waves are not conducted. That is the principle. Right. If you take type second degree AV block, there are two types of second degree AV block. Right. The first one is called Mobitz type 1. Mobitz type 1. Okay, Mobitz type 1. Okay, Mobitz type 1. ඒක මම කලින් ඕගොල්ලන්ට කියලා දීලා තියෙනවා Mobitz type 1 එකේ මොකද වෙන්නේ? The PR interval
progressively gets drop beat. Okay, there is a missed beat. The PR interval gets progressively bigger until there is a missed beat. Right? Okay, so PR interval gradually gets bigger, and then you have a missed beat. So that is called Mobitz type 1. And this phenomenon of the PR interval gradually getting bigger, and then causing a miss is called Wenckebach phenomenon. So first degree AV block, everybody clear? PR interval is prolonged, nothing else happens. All P waves have a QRS complex. Eka පැහැදිලිද?
Oh, sir.
Right. Then second degree block, the basic principle is some P waves have a QRS complex, the other ones don't. Right. So what you see is there are two types. Mobitz type 1 there is progressive prolongation of the mixed beat. That is Mobitz type 1. Mobitz type 2 කියන්නේ ඒ වගේමයි there'll be the ECG එකපාරට miss එකක් තියෙනවා. අර pattern එක, you won't see that pattern of the PR interval getting bigger before that miss. Right? So 2K miss somewhere in the middle of the ECG, but doesn't change before that miss. That is called Mobitz type 2. Type 2. Right. Okay. Right. I disconnect nane.
Oh, sir.
Second degree block के अभी के Mobitz type 1 Wenckebach phenomenon. Mobitz type 2 so there is a missed beat, but the PR interval does not progressively get bigger කියලා. It's one තුන්වෙනි එකක් ගැන කියන එක ඇහුන්නේ නැහැ නේද? තුන්වෙනි જાතියක් ගැන සමහර එක කතා කරන එකත්. Oh. So that ඇහුනේම නැහැ. හරි. Okay. So in the sort of second degree AV block, there is another group of patients who have a sort of a very fixed ratio between the P wave and the QRS complex. ඒ කියන්නේ P wave තුනකට QRS complex එකක්. හරි? That's called either a 3-to-1, 2-to-1 or 4-to-1 block. හරි? එහෙම කියන. හරිද? ඒක හරිද දැන් ඇහුණද?
ඇහුණා sir.
Good. Now the last type is a complete heart block. Complete heart block. Now in complete heart block, the main thing that you see on CGs, there is no relationship between the P and the QRS complex. P wave QRS complex එකයි අතර කිසිම relationship නැහැ. There is no relationship. Right? In other words, වෙන විදිහකට කිව්වොත් එහෙම P waves come independently, the QRS complex comes independently. Right? And if you take the P to P to P to P intervals, that is the same. P wave එක ලස්සනට පිළිවෙලට එනවා. හරි ලස්සනට පිළිවෙලට එනවා. QRS complex also comes. But there is no relationship between the P and the QRS complex. Harini, but measure wave to P wave, it usually comes at a regular rate. And the QRS complex also come at a regular rate. Eka harida teru ahunada eka?
Oh, sir.
Right. Okay. Right. Now what is this then? මේ මොකද්ද මේ? මේ ECG එකදී. So this patient has a bradyarrhythmia, bradycardia. And what is this? Is the diagnosis? මොකද්ද මේ ලා තියෙන්නේ? First degree block එකක්ද? Second degree block එකක්ද? Third degree block එකක්ද? කියමු බලන්න. මේ පන්ති හරි අමාරුයි කරන්න මේ ඒගොල්ලෝ ඉස්සරහ නැතිකොට. And also with these technical issues. Yeah. Why third degree block දිනක? ඇයි අපි මේක third degree එකේ? Right. So let me explain here. Yes. Oh, so there's no relationship. Ne P wave එක එනවා හැබැයි ලස්සන්ට මේ මෙතන P wave එකක් තියෙනවා. මම මේක අඳින්නම් මේක. එතකොට ඔයගොල්ලන්ට පැහැදිලිව පෙනෙයි මේක. So there is a P wave here. There. There. Somewhere here. Here. So P wave is coming almost in a regular way. නේද? මෙතන තියෙනවා එකක්. මෙතන තියෙනවා එකක් නේ. මෙතන තියෙනවා එකක්. QRS complex is also coming in a regular way. And there is no relationship between the P and the QRS complex. So that is a hallmark of a third degree complete heart block. Complete heart block. Right. Three bradyarrhythmia එකේ ඒක දැනගන්න ඕනේ. Right. What is this? මේ මොකද්ද මේ? So bradyarrhythmias are the things that you need to think of bundle branch blocks. Bundle branch blocks. So when you have a patient with a left bundle branch block, you will have a broad QRS complex, right? Broad QRS complex with a deep S wave in V1, right? Deep S wave in V1. And you might see this pattern, which is called William Marrow කියලා එකක් අපි කලින් මම ඔයගොල්ලන්ට උගන්වලා ඇති. ඒක පොඩ්ඩක් බලා ගන්න. William Marrow කියලා pattern එකක් එනවා කියලා. හරි. හරි. මේකේ තව abnormality ටිකක් තියෙනවා ඇත්තටම. ඒක මම පස්සේ කියන්න. මොකද්ද කියලා. හරි. right. හරි. දැන් ඊගාවට යම් බලන්න. මේ මොකද්ද මේ? right. මේක ටිකක් අමාරුයි. පුළුවන් ද බලන්න හොයාගන්න. මොකද්ද කියලා? ECG on chemotherapy, pre-syncope and shortness of breath කිසි වෙනවා ටිකක් ඔක හිතන්න. pre-syncope and shortness of breath එක patient කෙනෙක් එනවා. මොකද්ද මේකේ වෙන්න පුළුවන්? ECG එක නොබල මොකද්ද diagnosis එක? So cancer තියෙන මිනිස්සෙක් shortness of breath and faintest attacks එකක් આવොත් මොකක්ද හිතන්නේ ඉස්සෙල්ලා? And say තවත් basic කරන්න. Saturation එක බලුවම 80ක් විතර තියෙනවා.
Pulmonary embolisms.
Oh, pulmonary embolism. Hari. Then pulmonary embolism ගැන හිතාගෙන ECG එක දිහා බැලුවොත් now I told in the ECG you can get a right ventricular strain pattern. The right ventricular strain බලන්නේ අපි V1, V2, V3. Now can you ST elevations වගේ V1, V2, V3 speech segment changes නේද? මේවා තියෙනවා මෙතන. So that is right ventricular strain pattern කියන එක. ඒක තමයි. ST elevation තියෙනවා, can get ST depressions, inversions, all nonsense in this kids V1 to V3. Okay. කවින්ද ඇනවද? කට්ටුනම හිතන්නේ.
ඔව් ආයෙ දැන් එහෙනවා සර්.
ඇනවනේ. හරි. Okay, so oh. presentation එක ඔයගොල්ලෝ ගාව තියෙනව නේද? මේක මේ presenting view අයින් කරලා බලමුද මොකද වෙන්නේ? හරි වාතයක් වුණා මේ. කීක දවස් වලට මම දන්නේ අද මොකක්ද කියලා නේද? පේනවද ස්ක්‍රීන් එක?
ඔව් සර් පේනවා ස්ක්‍රීන් එක.
හරි. ස්ලයිඩ්ස් මාරු වෙනවා වගේ පේනවද?
දැන් නම් පේනවා සර් ලැග් එකක් නැතුව ස්ලයිඩ්ස් මාරු වෙනවා.
මෙහෙම try කරමු බලන්න. Right. So in pulmonary embolism then lamai you will have a RV strain, sorry, RV strain with a S1 T3 pattern. There a deep S wave in lead and a T inversion and a Q wave in lead 3. Right? That is a typical feature. Hari dekha. Kavindya ඇහෙනවද?
හරි සර් හරි. හෙලෝ.
hello. Oh, ඇහෙනවද දැන්?
ඇහෙනවා සර්.
කවින්දි අපි පොඩ්ඩක් පරක්කු වෙලා කරාට කමක් නැද්ද? මේක අර ඒකද දන්නේ නැහැ. මේ පැය භාගයක් විතර try කරමුද? මට අර මීටින් එකක් තියෙනවා දැන්. ඔව් පැය භාගයක් විතර පොඩ්ඩක් ආයෙ බලමුද මේක හරියයිද කියලා.
හරි සර් හරි. අපි පැය